Our next speaker is Melissa Wilson, and Melissa is the lead physician assistant in the melanoma program at the University of Pittsburgh Medical Center with Hillman Cancer Center. In addition, Melissa leads the AIMS Ask a Melanoma Expert program and is AIMS resident melanoma medical expert. So she's a great addition to our webinar today. Thank you so much for presenting today, Melissa.
You're welcome. I'm happy to be here virtually. I guess I'm glad we can do this over the internet and I didn't have to fly everywhere today.
Yes.
I'll go ahead and share my screen. I wanted to kind of frame this talk around sort of where we've come from and now where we're going, because I think that's important to understand where this whole process of the treatments that you have available to you now started, and sort of, show that without clinical trial medicine, which, unfortunately, a lot of people are scared of, clinical trial medicine made all of the treatments that are available as standard of care right now possible. So we can't get to where we're going without where we've been. So here's where we were. Back when I started with Dr. Kirkwood at the University of Pittsburgh in 2005, we still only had two treatments, really. One for adjuvant therapy and really 1.5 for metastatic disease. So in the past, for adjuvant treatment, we had a drug called interferon alpha. It was sort of able to be given in 2 formulations. One was 1 month of high dose IV, where you got like 50 times the normal dose that is already present in your body. And then for the next 11 months after that, it was an injection that patients self-administered 3 times a week. Pegylated interferon, same type of medicine. It causes both of these, cause an overall increase in the inflammation in your body to help try to identify cancer cells. The pegylated interferon was a once weekly injection. And patients would get that anywhere from 3 to 5 years to gain the full benefit. Unfortunately, these caused a lot of side effects. They caused a flu-like syndrome, fever and chills, muscle aches, lots of fatigue, and even depression. And also, this didn't really lower your overall survival. They did see a little bit of a risk of recurrence reduction, but overall, the risk and benefit ratio of this adjuvant therapy, unfortunately, compared to what we have available now, wasn't great. But it was what we had, and it's, it did help many people. In a metastatic setting, there were only, a few drugs that we could use. Carboplatin and paclitaxel really wasn't available until sort of the middle of 2009 as an approved agent. Carbazine was approved. It was given IV every 2 to 3 weeks. It caused the normal chemotherapy side effects. And what we know now is that, melanoma isn't very chemo responsive in many cases. We need to use and harness that immune system to really fight our cancer. Response rates were really low. Only about 8 out of 100 people responded. Same with the even stronger chemotherapy with carboplatin and paclitaxel. And then you had interleukin-2, which was a rough immunotherapy back then. Response rates with that were really still 15 to 20%. It also caused a inflammatory or cytokine response, which is a very general response to the immune system to fight your cancer. It had significant toxicities. Folks needed to be hospitalized. They would have really low blood pressures, high liver functions. We had some folks that would hallucinate during treatment. And so for that very, very small benefit, the toxicity profile, again, was not very good. So where we are now in adjuvant therapy, we have a lot of options. So right now, in addition to the interferon, which is by and large not used barely at all anymore, we have 3 really great options. Oh my gosh, I have a spelling error on the immunotherapy. I'm sorry about that. So we have the BRAF and MEK inhibitors. Those are the approved one is Tafinlar and Mekinist, or dabrafenib and trametinib. This is a pill. You have to have the BRAF mutation. I'm sure a lot of you that are listening probably are familiar with these agents, but I'm going to go through them kind of quickly so you know for sure. It's in pill form. You take them every day. It does have some side effects that include things like nausea, rash, joint pain, some fevers. By and large, those side effects can be very well tolerated. They're dose dependent a lot of the time. So if you're having significant side effects, your oncologist or treating physician team can reduce that dose and still maintain efficacy. In an adjuvant therapy setting, these drugs decrease your risk of recurrence by over 50%, which is amazing compared to the very minimal decrease in risk that we had before. There's also ipilimumab or Yervoy. It works a little bit differently. What it does is actually creates a scenario where your body ignores the stop signal. And what that means is that normally tumors are really good at telling your immune system like, hey, you don't have to make any more T cells. We're all part of the same team. You don't have to do that. But this actually turns that signal off. Oh, there we go. And so there are some significant autoimmune toxicities that can occur with drugs like ipilimumab and the PD-1 inhibitors. But it does decrease the risk of recurrence for about 41% at 5 years. It does cause increased survival. You can see the statistics at the bottom of the page. The biggest issue with Yervoy really truly is the toxicity profile. The autoimmune toxicities can be sometimes quite severe, require prolonged steroids. And then there are the PD-1 inhibitors. There's 2 of them that are FDA approved for adjuvant treatment. That's Keytruda and Opdivo, or pembrolizumab and nivolumab. They also decrease recurrence by over 50%. Some patients, about 20%, will have still some significant autoimmune reactions. Compared to Yervoy, they're much lower. About half of the patients that would have toxicities that are severe with Yervoy. This is an IV treatment. It's given roughly once a month. There's a little bit of variability depending on the dose, but roughly once a month for a year. So, and these have very few side effects in a lot of patients. So you can see now, you know, the adjuvant therapies, not only that we have now, are not only more beneficial, but they're also very much less toxic. In a metastatic setting, we use actually those same drugs, but there's many more that have been approved. And especially over the last 6 years, we've seen a significant surge in approval for FDA use of these medications. You still have Yervoy, you still have the PD-1 inhibitors. They also approved a combination of PD-1 and anti-CTLA-4, the IPI, together. We know that this combination offers almost twice the benefit as using single agent PD-1 or anti-CTLA-4 by itself. Now, when you combine those 2 agents together, sometimes you do get a significantly higher rate of grade 3 and grade 4 toxicities. So those autoimmune things that can happen with either of the 2 drugs occur in a little bit greater frequency and severity with the combination. But those medicines can, you know, those toxicities can be managed. And that's one of the things that, you know, I want to stress is that a lot of the questions that I get on the AIM website are, you know, oh, I don't really want to do these medicines with immunotherapy because they have such terrible, terrible side effects. And while that can potentially be true, they also are much better managed. And back when these were in clinical trials, you know, 10 or 15 years ago, we weren't as good at managing those side effects, but, you know, folks now are much better, and there are set guidelines, and the NCCN and ASCO have really great guidelines for community oncologists to really follow to treat those adverse events. And then in an adjuvant setting, really, we only have one BRAF-MEK combination, but in a metastatic setting, there are actually 3. So there's Mektovi and Braftovi, there's Mekinist and Tafinlar, and then there's Zelboraf and Katelik. They're also approved as single agents, Mekinist, Tafinlar, and Zelboraf in melanoma as well. And then just recently, there was a combination therapy of PD-1 and BRAF/MEK together. And the reason that this is such an important thing and a big advance in the treatment of melanoma is that what we sometimes see with the BRAF/MEK inhibitors is as a tapering off or a tolerability issue over time, where patients that have the BRAF mutation will respond initially, and then over time, unfortunately, their tumor will figure out a way around that. One of the ways that clinical trial medicine sought to overcome this is actually to attempt to use PD-1 inhibitors, which have a little bit longer period of getting started. They don't work as rapidly as the BRAF/MEK inhibitors do, but they do transition and over time have a longer response rate over time. So when they work for an extended period, like months and years. So really smart people thought, well, if we give the PD-1 inhibitor and get it started and give the BRAF/MEK to get an immediate response, would we see a more durable response overall? And they did see, a slightly higher response rate with Tecentriq in combination with Catelic and Zelboraf. It did have a little bit of a higher toxicity profile than giving either of those, combinations on their own, which is what we often see with combination therapy. But these are the ways, that we're attempting to overcome the resistance that you see with both immunotherapy and with targeted agents. And then you have, we had approval of TVEC, which is Imlygic. We do have a great use for this because these drugs work really, really well in a local or regionally recurrent environment where you see, cutaneous metastases and transit metastases, local cutaneous disease. These drugs work really great because they can be injected directly into the tumor and create a local tumor response. While they have great benefit locally, they do sometimes have systemic benefit, but this is lower than some of the other medications. So where are we going? I didn't want to spend a ton of time in this lecture talking about all of the clinical trials, because if you've ever gotten on clinicaltrials.gov, there are hundreds and hundreds of clinical trials that are going on for melanoma, which is an amazing thing. Funding and everything recently has allowed us to really have so many great options for patients that are refractory to the standard of care drugs. So even though we have a lot of things that are FDA approved, there are still patients that unfortunately will have progression of disease with those agents. So really, by and large, all of the research that's being done now is targeted toward finding a way to get around that resistance. And so some of the things that they're using are what are called third generation checkpoint inhibitors. Ipi or ipilimumab, which is very non-specific, was really the first generation checkpoint inhibitors. This is, very non-specific, just causes an increase in T cells. Then you have the second generation checkpoint inhibitors, which are the PD-1 drugs. Those have a more specific job. Their job is to really unmask the immune system. And then you have the third generation checkpoint inhibitors, which are LAG-3, TIGIT, and there's some other molecules as well that just had numbers, so it was a little bit harder to want to include those, which are given in combination now with the second generation checkpoint inhibitors to try to make them more effective. So it's sort of like trying to not only punch with your left hand, but punch with your right hand as well. So there are clinical trials that are looking at unlocking more of the PD-1 resistance that patients sometimes experience by using third generation or more specific checkpoint inhibitors. Atinostat is another example of that. It has a specific job in the metabolism of the tumor. And so it's also used in combination with some of the other checkpoint inhibitors to try to unlock that, that resistance. And then you have, GP100, which is actually something that is still relatively in clinical trial, but they've gotten enough data to show that for the first time ever, there is a drug that works really well for uveal patients. And so this is exciting on so many fronts, not only from, a general melanoma perspective, but especially for uveal patients. So GP100, there's that name. It's tebitantan. Yeah, we can't say it. So it's there. It's on the it's on the PowerPoint. We refer to it as GP100 in our clinic just because it's much easier for patients to remember. But it's a bispecific. It has one arm that attacks using, PD-1. It has another arm that attacks using the specific GP100 molecule. It reduced the risk of death by almost 50%. That is huge for uveal melanoma. Currently, because they're awaiting some FDA approval, it's available for an expanded access program. If you have difficulty or if you have uveal and you want access to this drug and your oncologist or whatever has trouble getting to it, you can contact me and AIM. We can try to work with your oncologist together to get that for you. There are still some requirements and exclusion and inclusion criteria. In clinical trial, this was only offered to people as first-line therapy. The expanded access is giving access to more people, but there are still some exclusionary criteria that have to be met. So it's not available to every single person in the world, but it is by and large much more available. And then there is TIL therapy, which is a really amazing treatment that is actually just one treatment. They take a piece of your tumor, grow you some tumor infiltrating lymphocytes, which are in another lecture in another time to explain that. But essentially what it does is it allows your immune system to have an actual antigen against your tumor. So it is more specific and knows how to attack. TIL therapy is actually also awaiting FDA approval. It'll be available at some specialty centers nationwide in America when that happens. Lifecell is the drug name. Essentially, they make you a specific tumor infiltrating lymphocyte. You do have to go into the hospital. They have to deplete your tumor infiltrating lymphocytes that you have. So I don't want to say a mini transplant, but they do have to prep so that they get rid of those ones that are present. So when they give you the engineered ones, you don't have a fight against your immune system. But it has amazing responses, a very, very durable disease-free progression. And then there's a little off the wall things, which is actually looking at the bacterial environment of your colon and small intestine. Some centers, big academic centers, are doing fecal microbiome transplants or giving pills that actually enhance the bacterial microenvironment to allow the immune system to be more healthy, to be more responsive to agents like PD-1. And there are some centers, University of Pittsburgh is one of them, MD Anderson, National Institutes of Health, they're doing it in California. So there's a lot of centers that are actually looking at the microbiome in the bowel to help unlock that resistance as well. And then lastly, there are the injectables. There have been a great surge, especially in the last few months, with using injectable therapy into the tumor directly, because we know that changing the tumor microenvironment, which is where the tumor actually lives in your body, is an extremely important part of treatment. Some examples of that are, and that's sort of where TVEC's sort of niche came from. So other examples of this that are in clinical trial are IL-12, oncolytic viruses, and this monoclonal antibody, which is CMP100. It acts as a TLR9 agonist, which is a toll-like receptor. And what it basically does is tells the body to pull T cells into the tumor. IL-12 works a little bit differently. It causes local inflammation, and the oncolytic virus, sort of like a Trojan horse, and unlocks the treatment inside of the tumor environment. So there are a lot of things, really too many to talk about in such a short period of time, but these are the really exciting, clinical trials that are out there. If you are at a community place that doesn't have an academic center, that doesn't offer a lot of clinical trials, here at AIM, we're always available to help you find clinical trials close to you, especially if you're in a situation where your melanoma didn't respond to standard therapies. Clinicaltrial.gov is a very good resource as well, but I'm always available if you have questions about things or need help getting in touch with a center of excellence for these sorts of clinical trials. So the take-home message of this entire talk is there are so many treatments now that are standard of care, but if they don't work, there's trials out there that are available and will help you get to them. There's some references, and I always end my thing with questions, but now I know we have a question and answer period, so save them for then. Thanks so much.
Thank you, Melissa. That was
You're welcome.
great information, just fantastic. Really fascinating and so hopeful for the future too.